thank you so much. I'm really glad to be here today and to talk about study partners in Alzheimer's disease research and focusing a little bit on what we learned from them and also what they learn when they participate in Alzheimer's disease research. So before I go on, I should just make sure to acknowledge all of the funding that supported this research, particularly my K Award from the National Institute on Aging. And of course, the materials and the content that I'm presenting today are my responsibility and not the views of the National Institutes of Health. So in terms of the overview of my talk today, I'll start by presenting a little bit of background on the biomarker transformation of Alzheimer's disease. I think that'll be familiar to many, if not most people here, but I want to make sure we're all on the same page so that because I think that's an important picture that lays the groundwork for what I think the social implications are of disclosing biomarkers. And then I'll share preliminary data from 2 studies I've been working on. The first of those is the Study Partner Availability Limitations Study, or PALS, and the second one is the RevealScan Study Partner Prospective Study. And then at the end, I look forward to discussion with all of you. And I should just say, I'm happy to save questions to the end, but if you have any questions or need clarification as I go through, please feel free to jump in and ask. So to start with a little bit of background, historically, Alzheimer's disease has been understood as a clinical disorder that's been defined by a pattern of signs and symptoms. So somebody who is having cognitive or functional concerns would go to a physician, and based on what they described, the clinician would diagnose them with dementia, and then they would determine that the most likely cause of that dementia was Alzheimer's disease. And so we've had this very close interrelationship between dementia and Alzheimer's. But scientifically, we're progressing, and these 2 threads are starting to pull apart. So right now, biomarker research is transforming Alzheimer's disease from this clinical disorder type to a continuum disorder that begins in a preclinical stage. So this preclinical stage is characterized by the presence of Alzheimer's disease biomarkers, particularly amyloid, tau, or neurodegeneration. But people are still cognitively normal. And you can have this preclinical diagnosis years or even decades before the onset of cognitive symptoms. So right now, there's research going on to both validate the preclinical Alzheimer's disease construct and also to try to identify therapies that could either delay or prevent the onset of dementia. And because later stage trials haven't been successful, the research has been pushing increasingly earlier, hoping that intervening earlier rather than later in the course of disease can result in identifying an effective treatment. So a key hypothesis for my talk today is that if we have the preclinical Alzheimer's disease construct validated, and if it becomes a target for therapeutic intervention, then cognitively unimpaired adults will be routinely screened for Alzheimer's disease biomarkers, and they'll receive information so that they can then either receive a prescription or not receive a prescription. And I think it's worth pointing out that this future is probably not that far off. Right now, Biogen has announced with a lot of fanfare that FDA is considering their application for aducanumab, with the decision expected on that in early 2021. And while that was an indication for mild cognitive impairment, I think we're close to seeing it, whether through off-label use or identification of another therapy, pushing into the preclinical phase. So a diagnosis of Alzheimer's disease before the onset of dementia, that is when somebody's still cognitively unimpaired, is obviously going to change the lived experience of Alzheimer's disease for patients, because what it means to be an Alzheimer's disease patient is very different when you don't have dementia, but instead are cognitively unimpaired. And additionally, it's going to change the experience for their families. And I'll talk a bit more about that as I go through the presentation today. So we have all of that happening, and I mentioned a bit ago that we have a lot of research going on right now to try to validate the preclinical Alzheimer's disease construct and also to conduct drug trials. And across the Alzheimer's disease research spectrum, participants are often required to enroll with a study partner. So Josh and Jason Carlish, who is my mentor at Penn, have done some work talking about why this is ethically important. That people enroll as a dyad that consists of the participant and the study partner, but it also serves a number of scientific purposes. So one of these is that the study partner serves as a knowledgeable informant, and their reporting on the participant's cognition and function serves both to confirm eligibility for a study, and also they can provide valuable inputs to evaluate an intervention's safety or efficacy. The other thing that's worth highlighting about the study partner is that often they're encouraged to watch out for the participants' well-being in preclinical Alzheimer's disease trials because incipient changes in cognition and function can affect the participants' welfare and well-being, so they can start to monitor now. So today I'm going to highlight two studies that are a little bit different in subject matter, but are thematically linked by study partners. So PALS is a study that aims to understand the factors that affect study partner availability. That is, if somebody doesn't have a study partner, that's a barrier to their research participation. And so how can we get more people into research by looking at the study partner requirement? And the RevealScan Study Partner Perspective study is looking to better understand the social dynamics of biomarker disclosure by looking at what study partners experience after that kind of disclosure. So the first study I'll turn to is PALS, and you'll see that Josh is listed as one of the co-authors on this project, and that's because we were able to use the consent to contact registry as a source of participants, and he's been helping with both study design and analysis of the data. And the idea for this project grew out of a 2018 paper that Jason, Josh, and I wrote talking about study partners and describing them as really being essential collaborators in discovering treatment for Alzheimer's disease. And the key point in this paper is that a recruitment challenge in Alzheimer's disease trials, and again, there are a lot of these ongoing, is that you're not just recruiting one person, you really are recruiting two people, the study partner and the participant. And so because you need to enroll a dyad, it's really two people for every one participant slot that you fill. And so we talked a bit about what some of the barriers we thought might be to study partner engagement, and also identified some initial interventions that we thought would be useful. So what we know is that if somebody doesn't have a study partner, this is a barrier to their participation because of the dyad requirement. And it can be a particular challenge in preclinical Alzheimer's disease trials because whereas somebody with MCI or a dementia level of impairment has a caregiver who can step into the study partner role relatively easily, people who have preclinical Alzheimer's disease are cognitively unimpaired, they're living their lives, they really don't have somebody who stepped into that caregiver role for them yet. So they're coming without already being embedded in a unit or a dyad. The other thing we've seen is that in registries like C2C or the UCSF Brain Health Research Registry, where they ask about whether or not somebody has a study partner available to them, about a quarter of participants say they don't have anyone who could be a study partner. Now, while they're saying that they don't have anyone, we don't really know what they mean by this right now. It could be the case that they really just have no one in their lives that they could ask to fulfill or take on that role. It could be the case that they're not willing to ask. So Josh has done some research talking about how people don't necessarily want to disclose their biomarker to other people. Or it could be the case that they have people in their lives who love and care about them. They'd be willing to share the information, but those people are not available for various reasons to be a study partner. So willing, but not able. Now, depending on what those causes are, we can hopefully identify interventions that can overcome barriers to finding a study partner and then test them to see what their effects are on recruitment and retention. So PALS is a qualitative study of adults who are interested in participating in AD research, and we use signing up for a brain health research registry as a proxy for that interest in Alzheimer's disease research. So the participants were 60 cognitively unimpaired adults between the ages of 65 and 85, and we picked that age range with a goal of approximating enrollment criteria in various trials that are ongoing. Participants were enrolled in either the UPenn Brain Health Research Registry or the C2C registry here at UCI. And they completed one 45-minute semi-structured interview by phone, and the interviews were transcribed and coded in vivo 12. So here's some statistics on who it was that participated in our study. We found that much like in Alzheimer's disease research more generally, we had participants who were a majority female. They were predominantly white, highly educated, and often had a family history of Alzheimer's disease that helped explain or put into context their motivation for participating in research. Now, as part of the interview, we read a vignette to them that talked about a hypothetical Alzheimer's disease trial. So we said that investigators were testing a new drug that could delay or prevent the onset of Alzheimer's disease in people who are at increased risk of developing dementia. The study is expected to last 3 years, and you would need to go to the study site every month to receive medication, and every 6 months, you would need to go through cognitive testing with the implication that your study partner would need to come with you. And we asked people to imagine that they did want to join the study. So they'd already made the personal decision for themselves that they wanted to be in it and now had to think about a study partner. So the first thing we wanted to understand was whether or not they would be willing to ask someone to serve as their study partner. So we had this large group of yeses who did talk about needing to have courage. We had a very small group of no's, unwilling to ask, and then a few maybes who really did think it mattered about contextual factors like their own personal level of commitment. And in some cases, people expressed concerns that by telling somebody they were participating in Alzheimer's disease research, that would be conflated with a diagnosis of Alzheimer's disease, and they were quite worried about that. We then went on to ask who they would be willing to ask to be their study partner. And by order of frequency, we saw most often it was a friend, and then a spouse, an adult child, siblings, in-laws, or other relatives. And people could list more than one person. Interestingly, at this point, we see that 2/3 of participants were only able to identify one person that they would be willing to ask. So people really didn't have a very deep bench of people. And so when we think about what this means for recruitment into trials, even though these people were willing, ostensibly to participate, if that person who they identify as their one option for a study partner isn't willing or able to participate with them, that could knock them out of potential eligibility. Another quarter of participants could find 2 people, and most married participants, I think unsurprisingly, indicated that they would be willing to ask their spouse, which becomes interesting because we know that spouses are overrepresented amongst study partners given the rates of marriage that we see in the general population, which might have implications for people who have non-traditional family structures. In terms of why they would be willing to ask a particular person they had identified, most people talked about their relationship with the prospective study partner being very close, that that person was interested in their health, and that they had a relationship that was marked by reciprocity. They also talked about the study partner, him or herself, as somebody who would be willing, who was interested in science, and was very reliable. So here we have a quote where somebody says, well, because of the closeness that we have, I would be willing to ask. I think they would be more than willing. People also pointed to logistical considerations, which is not surprising given the necessity for the study partner to show up for visits. So people talked about their availability, whether or not they were still in the workforce, the geographic distance they would have to travel to be a study partner, and whether or not they met the requirements of seeing them often enough to be able to serve as a study partner. And so for some people, they were chosen because they were the most available. And then the last thing we saw is that people talked about their own desire to participate. So they would be willing to ask just because they were interested in the study. We wanted to know if the study partner role seemed burdensome to them. So 25% of people indicated that yes, they thought it was a lot to ask somebody. A third indicated that no, it didn't seem like very much to do that. But then we have this very large middle group that says that it could be maybe or somewhat burdensome. And what these quotes highlight is that people really looked at contextual factors in the prospective study partner's life to think about how burdensome would be. So if somebody was working, for instance, or they have a young family, or if they had to travel a long distance, they thought that would be more burdensome for them than it would be for, say, a retiree. And then the second quote talks to similar things. They go through a series of questions. How far away do they live? Are they employed? Do they have an illness themselves that they're managing? So it's difficult to say how burdensome it would be. So they really are evaluating the study partner holistically. Of course, we wanted to know about the, if we'd asked about the downsides, we should think about what the upsides are of having somebody serve in the study partner role. And the most common answer that we got was research integrity. People talked about the study partner as somebody who could be a knowledgeable informant. They could promote adherence to a study. They could ensure participant safety and also help with recruitment. But once we looked outside the scientific rationales for it, we see a number of relational explanations for the benefits of a study partner. So the first thing we see is that they could provide support for their participant in the present. So people talked about wanting to have approval from somebody else that they were participating. They could also, they thought, help them with comprehending the study because it would be a second set of eyes and ears who, for example, sat through the consent process or heard information. And they could also provide support in logistics and travel. The next things we saw were positive experiences for the study partner, him or herself. So they talked about how it could be educational for the study partner to be involved in research, and also that it would strengthen the relationship and that that could be gratifying to the individual because it makes you feel good to help somebody that you care about. And then a very interesting finding, and you'll see this as a theme that starts to pull across the work that we've done, is that people talked about a potential benefit as support for the participant in the future. So this was future preparedness in case somebody were to experience cognitive decline. They would have already had information about risk and started to anticipate that there could be cognitive decline and plan for it. And that could be in terms of thinking about being a surrogate decision maker or in terms of being a caregiver. And people also talked about how helpful it would be to have somebody monitor them for cognitive symptoms. So just flagging that for future. And then we wanted to know what would make it easier or more likely for that person they identified to serve as their study partner. So we took this list from the paper that we had written, I showed at the beginning, and we asked about telephone visits, the researchers actually calling the study partner themselves to handle recruitment instead of asking the prospective participant to talk with or identify a study partner, video chat visits, having multiple people who could share the study partner role. So if I had an adult daughter and an adult son, maybe they could trade off visits, having visits on weeknights, free transportation, or offering modest payment to study partners. And what we found is that when we asked people what would be most useful, a third of them said that it would be most helpful to have some sort of remote visits. So having somebody who could do a video chat or telephone visits. And I think this might have all seemed a little bit more implausible when we started PALS, but now that we've had COVID intervene and we've seen a shift to telemedicine, I think that the idea of having a remote visit like that feels a lot more feasible to people. So I'll be interested in seeing if we can move the needle on this. The other thing I wanted to highlight before moving on is that some things like free transportation didn't come up very often as something that would be make it easier for somebody to be a study partner. But when we parsed it out, it actually turned out that was site specific. So people at Penn in a more urban setting identified that as helpful more often than somebody from the UCI site. So I think there are still ways in which we could refine this and think more about targeting populations that we're particularly interested in, like underrepresented groups. So understanding study partner availability in these ways hopefully can help us with recruitment. And as just, by way of summary, we know that PALS participants had only 1 or 2 people they'd be willing to ask, and many, despite appreciating the role's benefits, did think that it could be burdensome. Interventions, especially remote visits, might make it easier for people to identify a study partner and participate in research, and additional work is needed to decide whether or not these interventions improve diversity in research participation, and that's hopefully going to be an avenue for future research. So having talked about PALS a bit, I'm actually going to pivot and talk about a very different aspect of the study partner role. And the study that I'll be sharing preliminary data from is the Reveal Scan Study Partner Perspective Study. So just to give a little bit of background on what motivated us to conduct this particular study, we have been doing a variety of work at Penn on understanding how disclosure of biomarker results to cognitively unimpaired adults affects them. And so we had this paper that we published in PLOS One and some other work. And what we found when we talked with people is, the study is called Socrates, Socrates 1. We have a second study, Socrates 2, that looks at ApoE testing disclosure, but I won't talk about that today unless somebody has questions during the Q&A. So amongst Socrates 1 participants who received an elevated amyloid PET scan result, when we asked them how it compared to other kinds of medical information, they said that it was a more sensitive piece of health information. So very evocatively, one of our participants told us, well, a colonoscopy isn't going to change who I am. This is my brain involved. So they really did see this as something that uniquely impacted on their identity. Now, they understood that they had an increased but uncertain risk of Alzheimer's disease due to that elevated amyloid PET scan result, which is good to know because sometimes a reason against disclosure is thinking that people won't understand. People also had emotions that ranged from sadness and resignation. Oftentimes they had sort of anticipated that they would get this result given a family history of Alzheimer's disease. But some people, interestingly enough, even after they got an elevated result, talked about hopefulness. And we probed a little bit deeper and asked people why that was. They cited reasons like having family members who had lived into a healthy old age, having a lot of faith in science, that science was going to identify a cure for them before they developed dementia or that would be able to reverse their dementia. And in some cases, they just described themselves as lucky people, and they thought that that luck would protect them and that they would not develop Alzheimer's disease dementia. Getting this information about amyloid plaques in one's brain also leads to a reinterpretation of memory concerns. So people talked a bit about if they had subjective cognitive complaints at baseline, that they now understood that in terms of the onset of dementia. And again, I would just reiterate that people in Socrates were cognitively unimpaired. So they were testing as cognitively normal, but still had these subjective cognitive complaints. There were some people too who had not had any memory concerns at baseline, but once we told them that they had elevated amyloid, it was almost like a stereotype threat, and they were now reinterpreting what they had previously thought of as senior moments or slips in terms of incipient cognitive decline. And while it's not a focus of today's talk to think about people who have a not elevated amyloid result, for them, those who had memory concerns at baseline, they were actually in some cases quite frustrated to get a not elevated result because they now felt like they had lost any sort of explanation or understanding of what was causing those memory concerns. Additionally, people in our sample explained how they had adopted new health behaviors. So people talked about eating more nuts and berries because they'd heard it was good for their brains. We had at least one person who went on at some length about how much they hate fish, but how they were now making themselves eat it at least once a week because of the brain health properties. And people were also engaged in changing their future plans. And changing future plans could be everything from cleaning out your attic to downsizing your house to move closer to somebody who you thought could be a caregiver if you were to develop dementia. People made trade-offs between staying in the workforce longer versus retiring sooner and checking items off their bucket list. They also were doing things like revising wills, writing out advance directives, and doing other kinds of long-term financial planning. Now, the interesting thing here is that when we compared the responses between people who had an elevated result and those who had a not elevated result, we saw much more frequent changes around future plans happening in the elevated group. But when we asked them why they were making these changes, they really actively denied in most cases that it had anything at all to do with the elevated amyloid result. They typically said it was because of their age. You know, everyone my age should be doing things like this. Or they talked about it in terms of life stage. So one person said that they had relatives who were in various stages of decrepitude. That's a direct quote, and that they were just doing this because they had these family plans. So it's not clear, you know, obviously it's a qualitative study. We don't know which direction things were going. Maybe we actually were seeing a reduction in planning from some people who had a not elevated result. One even told us that maybe they were less motivated than they had been before to do things just because they felt like they had been given a little bit of a respite. Another thing that we saw in the results is that people had really engaged in a robust decision-making process around whether or not they should disclose their amyloid PET scan result from other people in their lives. So the disclosure decision-making model is a really helpful way of thinking through how Socrates participants were going through this process of deciding whether or not to share non-visible health information, that is their amyloid PET scan result. And according to the disclosure decision-making model, people go through 3 assessments when deciding whether or not to tell somebody this information. So the first thing they do is they assess the personal health information by weighing 5 factors. They ask themselves how stigmatized the information is, whether or not they were prepared. So the preparation refers to how much I anticipated the result. And in our sample, a lot of people did anticipate it given a family history of Alzheimer's disease. They looked at the prognosis or the likelihood of different outcomes, whether or not there are symptoms that might make disclosure more necessary to other people because you can't hide them, and then the relevance to other people in terms of things like health, but also, as we saw in some of our results, whether it be relevant for future plans that people had or were sharing together. Now, if that all speaks toward disclosure, people go to the second stage, which is assessing the potential recipient of the information. So they take into account the relational quality, how good the relationship is between the parties, and the discloser also thinks about anticipated reactions that they might have. And then the third phase is that they assess what's called the personal disclosure efficacy, which is really just a shorthand for saying their ability to share the information with this person and produce the result that they desire. Now, if all of those stages go well and indicate disclosure is appropriate, people can go ahead and disclose or enact the message. People can opt out at any time and decide not to disclose. And of course, this is a cycle that you can re-enter if information or context changes and you decide that you want to share in the future. So in Socrates 1, we saw participants sharing their result with at least one person, most often family and friends. Interestingly, and again, unsurprisingly, people really weren't sharing very often with colleagues. They were sharing even less often with bosses, supervisors, employers. And then we saw very low levels of sharing altogether with healthcare providers, which was an interesting finding. Now, the reasons people gave us for why they had shared with people had to do, they traced very nicely onto the disclosure decision-making model that I just described. So they talked about having a good or close relationship with the recipient. So when it's your spouse, I tell them everything, and so I'm going to tell them this as well. They also talked about anticipated positive reactions. So one of those reactions was provision of emotional support, but I'm going to highlight two other ones of interest on the next slide. The third was the relevance of the result to others, feeling like it could impact on their health and well-being. And then the fourth, which I just thought was quite charming from the sample, was that they shared with people because they wanted to promote Alzheimer's disease research. They both wanted to see the studies that they were enrolled in succeed in recruitment and retention, and they wanted other people to be able to enjoy the potential benefits of participating in research. One person said it was a chance to encourage your friends to be a part of history. So as I said on the last slide, these anticipated positive reactions, some of them were around emotional support, but there were two that were really distinct. And again, this is where I foreshadowed in PALS data. People talked about wanting the other person to observe them closely for cognitive changes. So that's the first quote. I did ask her, and I wanted her to be honest with me. When people start seeing symptoms, sometimes we're in denial. And I said, tell me if you start seeing them. If you start seeing patterns, I need to know. So already this is one of the reactions, is people want somebody monitoring them or watching over them. And the other one is this anticipation of a future caregiving role. They want people to start to get ready and internalize the information so that they can prepare to be both a surrogate decision maker when the person becomes incapacitated, and also to be a caregiver in that very physical, intimate sense. So if I did get Alzheimer's, she would probably eventually be involved in making decisions about my care and things like that. And I shared the amyloid PET scan result with her so that we could both better prepare as a couple for financial and medical decisions that might come down the road. So that's our reasons for sharing, and then I'll highlight a few reasons for not sharing. One of them is just the inverse of the good relationship. It's the poor relationship. People didn't want to share with their ex-wife. They didn't want to share with their estranged brother. All makes sense. The second cluster of reasons for not sharing had to do with negative anticipated reactions. Now, some of these were just that the person was already burdened and you didn't want to further overwhelm them or make them sad or upset them, but other ones had to do with changes that they thought it could actually create in the relationship. So some people said, I want my kids to keep living their own life. And if I tell them this, they're going to feel like they have to parent me, and I don't want to get in the way of them taking a job and moving across country or pursuing their own dreams and goals. Other negative reactions had to do with social stigmatization. So our society is sometimes described as hypercognitive, and for people who shared this, they were worried that they might be excluded from things like a card group that they were already participating in. Or one person said they were nervous they wouldn't be able to sit at their preferred table in their continuing care community. So they really did see this as a social problem for them. And then a few people talked about discrimination in the context of work, in the context of purchasing insurance, and in the context of purchasing housing. And so those are three issues that I'm really interested in with my legal background, and I'd be happy to talk a bit more about those. But I think they were very well-founded fears of discrimination because the law is not well equipped to protect people who have Alzheimer's disease biomarkers. And then the third reason for not sharing was just a lack of symptoms. So people felt like it wasn't necessary to share because they could still drive, they could still balance their own checkbook. They weren't having any problems that made it necessary to share with others, but they acknowledged that they could loop back and that they could tell them if it became necessary because of symptoms. And then the last point I'll just make here is that a few people hadn't shared yet, but not because they were unwilling, just to that last assessment in the disclosure decision-making model about message efficacy. They really wanted to make sure they delivered the message in the right way, at the right time, with the right people present. And so some of them were just delaying so that they could get those ideal circumstances to share their message with the intended recipient. So that's one thing that was informing the work in the REVEAL scan study partner perspective study. The other thing is that while we were analyzing the data from Socrates 1, we were seeing anecdotally in clinic that study partners were coming in and they were saying, well, again, reporting out on the well-being of the participant to the investigators. And they're saying, he is handling this really well, but it turns out I'm a wreck. Knowing that he has amyloid is causing me a lot of discomfort because I'm anticipating anxiously a future where I might be a caregiver. So what we did in this paper is we talked about the dawn of the pre-caregiver. And the pre-caregiver is somebody who is, in fact, a recipient of information about biomarkers. And what we see is that individuals who receive a biomarker result learn something about their risk of going on developing dementia caused by Alzheimer's disease. But family members are also learning something about their own risk, and that is their risk of becoming a caregiver. And what we know is that in the United States, our system has repeatedly, and unfortunately, I think, reinforced the reliance on informal caregiving. So right now we have 5.8 million Americans with dementia and more than 16 million unpaid familial caregivers who take care of them. And while caregiving can have upsides, we also know that it can have economic, psychological, physical, and social consequences. And so it's really not to be underestimated that people anticipating this have something to be anxious about. And additionally, we see that people start to engage in monitoring. And so we don't think that this is as intimate or arduous as being a caregiver for somebody with dementia, but obviously there is sort of this new state of relationship that emerges when somebody now learns that their partner or another loved one is at risk of dementia. So taking all of these findings, we were really intrigued and decided that we wanted to study the social dynamics of biomarker disclosure. And fortunately for us, we were able to take advantage of the study partner requirement to do that, because study partners typically accompany people to disclosure visits, they learn the results, they're there with the research, they're thinking about it, and we were able to ask them what that experience was like for them. So the RevealScan Study Partner Perspective study is a qualitative study of study partners, and I've now used study far too many times in this sentence, who learn someone else's amyloid status. We enrolled 80 adults who were study partners of cognitively unimpaired 60 to 75-year-old adults who had learned their amyloid result through participation in a parent study, RevealScan. And we were able to balance on amyloid status and study partner participant relationship, again, thinking that being a spouse to somebody might be a little bit different than being a friend or an adult child. Participants completed one 30-minute interview by telephone, and then we were able to transcribe and code their interviews in vivo. So here we have the characteristics of the study partners. They were balanced again on male and female. We were able to recruit about 1 in 5 identified as Black or African American. And then we had a majority of spouses, which again is reflective of who's serving as a study partner in Alzheimer's disease research generally. And even among study partners, we saw a high incidence of family history of Alzheimer's disease. Now, we wanted to see what study partners understood about whether they knew the result, and then also if they understood what the result meant. And while we did have some people who didn't know the result, which was an interesting finding in and of itself, that there were people who were kind of along for the ride in research and yet didn't know what was happening. Most people were able to give us a relatively good explanation of what the result was and what it meant. There were a few misunderstandings. So some people who had received, their loved one had received an elevated result told us that risk was low or decreased or average. And a few people who had gotten a not elevated result said that it was a high or increased risk. But generally people had it pretty well down. Study partners experienced a range of emotions after they had learned the participants' amyloid PET scan result. So when we had done Socrates 1, when we asked people who had gotten a not elevated result, like the most common feelings that people described were relief and a feeling that their future was bright. And this again was this idea that they had worried about it, and now we'd given them information that took the weight off of their shoulders. It makes for very easy qualitative research coding when everybody uses relief over and over, and then you can just code for that. The feelings are a little bit more diverse amongst the elevated group. Some people described feeling neutral or having a sense of disappointment. We saw some worry, and then we saw a few people who talked about having more sympathy or patience because now they felt like memory slips or lapses that they had worried about before or maybe been critical of. They had some new context that gave them understanding and more patience. Study partners also talked about how this had given them additional insights into the participants' memory. So some people said, about half said that their feelings about the participants' memory were unchanged, although as this quote illustrates, these are people who already had been joking about memory or having some memory complaints all along. Then some people talked about how they were being more aware or more observant. So this participant talks about how it's so hard that you don't know whether it's decreasing the memory because you're just getting older, or if it's actually the onset of Alzheimer's, you don't know, but we see this hypervigilance happening in some people. And then for a few people, it was nice because it validated things they had already suspected. And again, I just feel like I have to reiterate as I go through this, I find these so interesting because these are people who were testing at least as cognitively unimpaired, even if they had subjective cognitive complaints. So once we line up the results of Socrates 1 and the RevealScan Study Partners study, what we see is that while these are two different samples, that we see a lot of similarities between them. So a majority of the study partners knew the loved one's result and could explain it. They described feeling relief after a not likely result, or having sadness, concern, or resignation after getting an elevated result. They had new insights into the participant's memory, and nearly all of them denied that learning the result had changed their relationship with the RevealScan participant, so they didn't think it had directly changed the dynamics. But they did report changing future plans, so they themselves were taking on they were thinking about whether or not they should be seeing grandchildren more often now, or if they should be moving closer to somebody, or they were planning for caregiving in the future. And they did all of this in light of the result that they had gotten. So while we're still going through and analyzing all of this data, I think it's a really powerful signal that an Alzheimer's disease biomarker result really does impact not just on the individual who learns the information, but really onto the family system and the social network that they're embedded in. So my hope is that we'll continue to do research to really understand this pre-caregiver role so that we can influence the future of clinical practice. So with that, hopefully I have been able to convince you all today that study partners both help us conduct Alzheimer's disease research and also that they can help us anticipate the future of Alzheimer's disease care. So we really can take this as an opportunity now to understand what's going to happen once we translate current research findings into care in the future. I want to thank all of you for bearing with me, especially with the technical glitch in the middle. Again, I apologize for that. And then of course, this is the members of the P3MB lab that I'm part of, and they've all been really involved in the work that I presented here today. So thank you so much.